आता वाता कुछ है नहीं, खाली फंसा।
मैम वी आर लाइव।
Am I audible?
Yeah.
Yes.
Am I audible?
Yes, Dr.
Yes.
Can I to start these slides?
नमस्कार मंजू जी। नमस्कार मंजू जी।
नमस्कार नमस्कार नमस्कार।
Dr. Chaudhary, good evening, good night, whatever it is in your time zone. So welcome everybody. Welcome. I welcome all the faculty members, the senior and the colleagues and the delegates in this masterclass series on medical disorder and ART pregnancies. This is organized by IFSUP Chapter East, and this is the second in the series. And today we'll be talking about GDM and ART pregnancies, the possible complications. And I really assure you that you'll have a very great academic fiesta today. And with this, I hand over I invite Dr. Manjusha, the Secretary of IFSUP Chapter East, to kindly start this session.
Thank you so much, Dr. Vaida, for the kind introduction. As you have already told us that this is the second episode, and today we are going to discuss the very practical aspect of GDM. But before we begin, I seek the blessings of Reverend Chandravati Madam. She is the umbrella under the very able leadership and at whose care we all flourishing and trying to learn the science and art of obstetrics and infertility and gynecology. Blessings.
Am I supposed to talk, Manjusha?
Yeah, ma'am.
आशीर्वाद तो आप देना ही पड़ेगा.
मेरा I don't think we need to show all this every time, because IFS is something where I think I need no introduction. I'm very proud of Manjusha that she's all the time busy in creating new areas of involvement for each senior person, and would not allow in Dr. Manju Shukla to sleep in the afternoon and leave behind me. It is a great pleasure to be present on the second episode of this masterclass, and as far as possible, I will be there to listen to these interesting cases, and maybe for some time the debate as well. I wish luck and success to all these programs, and Manjusha and the team, all your endeavors and your efforts to keep IFS alive and keeping it Lucknow on the top at the head office, and always bringing out new ways of having interesting topics in your webinars. So go ahead with all your case presentations and keep us involved and keep our brains active to work day by day on these programs. Thank you.
Thank you so much, ma'am. Your blessings are always the most, are very encouraging, and we can't do anything. We can't do anything besides them. So let's start with the first session. That is the crosstalk on insulin therapy in GDM. And the experts are Dr. Manju Shukla ma'am. She's the ex-professor Obs-Gynae KGMU Lucknow, and she needs no introduction. She is the most loving seniors we have with us. And the next expert we have is Dr. S.P. Jaishwar ma'am. She's the professor and head Obs-Gynae KGMU. Thank you, ma'am. Thank you, ma'am, for joining us. And
thank you so much, and सबको नमस्कार.
Thank you, ma'am.
Thank you. मुझे वैसे ज्यादा नहीं आता. Shama, you have to take care. अच्छा.
कोई बात नहीं, सबको जो पढ़ा रहे हैं उनको ज्यादा आता है.
मैम.
हाँ, ठीक है.
मैम, आपकी आवाज थोड़ा ब्रेक हो रही है.
हाँ मैं ना बड़ी मुश्किल से तो लॉग इन नहीं कर पाई हूँ, मेरा
हाँ,
वो नहीं चल रहा है ना, लैपटॉप।
अच्छा मैम, नहीं
चलो।
मैम अभी सुनाई दे रहा है। तो मैम आई रिक्वेस्ट यू मैम, डॉक्टर मंजू मैम, टू काइंडली इंट्रोड्यूस आवर एंडोक्राइनोलॉजिस्ट द डॉक्टर संतोष चौबे टू द ऑडियंस.
Dr. Santosh Chaube is the Senior Staff Specialist Endocrinology, Department of Endocrinology and Diabetes, Division of Medicine. क्या जाने, पढ़ भी नहीं मिल रहा. Cancer and
मैम डोंट बॉदर, इज फाइन. मैं अपना बता दूंगा. आपने बता दिया, नाम ले लिया, दैट इज मोर देन एनफ. डोंट वरी अबाउट दैट. मैं बोल दूंगा जो मुझे बोलना है. ठीक है मैम. आप सब लोगों ने पढ़ाया हम लोगों को. आप लोगों को याद नहीं होगा. 190 बच्चों को पढ़ाते थे, कहाँ याद
सुनो
रहेगा.
ना, नहीं सुनो तो बात ये है कि बुढ़ापे में आंखें हो जाती हैं. अब पहले इलाज करो तब बोलो. इन लोग ने पहले से मेरे को दिया नहीं कि मैं बोलूं, और तुम जैसे वीआईपी लोगों को इंट्रोड्यूस कराने में तो बड़ा प्राउड फील होता है यार. अपने बच्चे अगर
मैम
तो
आपने नाम बता दिया, दैट इज एनफ. मैं आगे बोल लूंगा जो मुझे बताना है.
प्लीज start your talk.
Okay, so we will, as Dr. Manjusha ma'am has already told us, that we will be discussing on three case scenarios. So we start with the first case, and this case will be presented by Dr. Shipra Bagchi. She is a very renowned infertility specialist and runs the Dr. Bagchi IVF Center in Lucknow, and she has done her MD Obs-Gynae from King George Medical University. So over to you, Dr. Shipra. You can start with your first case.
Thank you, Dr. Varda. Thank you for the kind introduction. Good evening to everyone, to my seniors, colleagues, and the juniors. And Dr. Santosh, I'm very excited, and it's a very pleasure to meet you on screen today. And you have helped me managing so many gestational diabetes patients in my practice. And now I am actually missing you. You have gone to Australia. Okay, so without wasting much time, I will be moving ahead to the case number 1. A 26-year-old primary gravida with a BMI of 23 kg per meter square and running through 24 weeks of gestation. She has conceived through IUI. She was diagnosed as a case of gestational diabetes at around 18 weeks when her DIPSI test, that is 2-hour blood sugar after 75 gram glucose, came out to be 184 milligram per deciliter. And after that, she was put on MNT, that is medical nutrition therapy, and she was advised approximately 30 kilocalorie of per kg per day diet. And but her sugar is not controlled. We couldn't reach the glycemic goals, and her blood sugar fasting is 128 milligram per deciliter, and her 2-hour postprandial is 184 milligram per deciliter, even after the more than a month of MNT. So, Dr. Santosh, so I will be coming to our queries, and now what to do? Should we start insulin? Number 1, and if we have to start insulin, what type of insulin and in what doses? And the third is how to monitor blood sugar with the insulin therapy. Yes, Dr. Santosh.
Thank you. Thank you, Dr. Bagchi. It's good to see you as well.
Thank you, sir.
On screen, of course, off screen as well. And thanks for sending your patients. If you felt me that I have been helpful, I'm grateful to hear that. So firstly, I will pay my regards to all my seniors और चंद्रावती मैम, आप लोग तो मैम, और मंजू शुक्ला मैम, जयसवार मैम, आप लोगों ने हम लोगों को पढ़ाया है, और अक्सर क्लास हम लोग बंक कर दिया करते थे, फिर भी हमें ज्यादा डांट नहीं पड़ती थी. तो मेरे ख्याल से
अरे भाई,
आप लोग हम लोग
अब उसकी डांट अब पड़ेगी.
मैम पेट डिपार्टमेंट था गायनी हम लोगों का.
अरे भाई, गायनी में यही लगता
उसका
था
ये है
कि लड़के कुछ ही बोल के चले जाए, डिपार्टमेंट छोड़े, बहुत दिन तक यहाँ रहेंगे तो इधर उधर ताक झाक करेंगे. इससे
हाँ मैम, वही मैं कह रहा हूँ कि वो फेवरेट था हम लोगों का. तो वो अभी फील सो ग्रेटफुल कि आप लोगों ने इतना, और हमारे मैम जितने भी टॉपर्स थे, सबकी आप लोगों ने जो. जी मैम. जो हमारे बैच के
उसका
टॉपर थे
बदला
उनकी
जो है अब
जी मैम आप बताइए।
आप कह रहे हो?
मंजू जी बोलिए, आपकी बात हो नहीं पा रही है। हाँ
ब्रेक हो रही है मैम।
ये क्लास बंक करा तो करा, अब उसका हमसे यहाँ ना बदला निकालना।
मैं नहीं मैं बदलाव क्या निकालूंगा, मैं मतलब बहुत बोरिंग बात नहीं बताऊंगा, अच्छी बातें बताऊंगा जितना मुझे आता है।
नहीं,
बट मैं
मुझसे
ये
ना
कह रहा था,
पूछना कुछ।
अरे नहीं मैम आपसे, नो नो नो। तो एक दो लाइन अभी केस के पहले, शिप्रा इफ यू अलाउ मी आई विल से few more things before we go for the case discussion and all.
Sure, sir.
ये तो प्रीटेक्स्ट था, और दूसरा ये था मैम कि हमारे जितने टॉपर थे वो 10, मेरे ख्याल से 20 में 18 या 12 14 लड़कियां होती थी, उन सबको आप लोग जैसे ग्रिल करते थे, बहुत बढ़िया लगता था मैम, एकदम सुकून मिलता था। we felt so great. अभी का फिलहाल का ये मैम कि आई वाज इन लखनऊ, ऑफ कोर्स हमारे सारे फ्रेंड लोग हैं और सीनियर्स हैं। मनीषा मैम थैंक यू, एंड आईएफएस वेरी थैंकफुल इफ यू इनवाइटेड मी। अभी आज मैं एक्चुअली मैम क्राइस्ट चर्च आया था, और यहाँ पे एक कॉन्फ्रेंस हो रही है हम लोगों की एंडोक्राइन सोसाइटी ऑफ ऑस्ट्रेलिया की। इसके साथ में यहाँ पे जो होता है उसमें सोसाइटी ऑफ रिप्रोडक्टिव बायोलॉजी एसआरबी एक इनका ऑर्गेनाइजेशन है, उसका साथ में मीटिंग होता है। So they had the meeting together, and the first lecture which I attended today actually was about placental biology. So that was very interesting. And there was someone, a speaker from Adelaide and La McQueen Hospital ka hai. So they have done some research, and what they said, which was, of course, I didn't know that they looked at the data on the people who had the fast food, and around 18% of females who were unable to conceive in comparison to the people who were taking the normal diet, like 2 portions of fruits and all. So I think the food etc there are so many factors in infertility we still have to explore, rather than, of course, we are not probably in a society where we're living as a medical professional that okay we are going for intervention for everything. We have to think, of course, the broader spectrum. So wo to khair aap log ka department hai.
True, Dr. Satish. As you know, the diet and life modification plays very important role in conception, especially as today's diet is this burger and cheese, and they are all responsible for PCOS. And PCOS is the common cause of anovulation and infertility. And along with that, there's an increased BMI also. Increased BMI or increased weight itself is responsible for hormonal disbalance and anovulatory cycle. So this all ultimately leads into infertility. So that is very important.
I think they did some analysis, and they took out the patient, obesity वगैरह को हटा दिया उन्होंने वो systemic analysis करके, और उस सारे वेरिएबल्स को हटाने के बावजूद जस्ट डाइट को फोकस करो, तब भी आप देखोगे आपकी if you patient are having all the pizza, pasta, burgers, they are finding it hard to conceive. So
yes,
interesting, it was very interesting. So back to the diabetes part. So diabetes, of course, is something which is now ubiquitous, and we all see not only in the patient but also in the family members. I think it's very hard to imagine that anyone who doesn't have a family member affected by diabetes, so common. So the management has become more and more challenging and complex, at the same time rewarding if you successfully manage those patients or cases. So about Dr. Shipra Bagchi's case, I do not have many slides, but I have 3 slides. So if I don't know Saurabh has access to the slides or not, I did send it to Dr. Manjusha today. If you want to use the slides, he can use, otherwise I will just speak. And I would like the audience to ask questions in the question box, and if someone can take their questions and talk to me, that will be great, because the whole purpose of this meeting is that we should be able to have some good discussion, and I should be able to show some some guidance or something for your patients who can avail the better glycemic management facility. So if I start from here about the case, who is 26 years of age. So age-wise, if you look at the risk factor assessment for gestational diabetes mellitus, the age, the ethnicity, being Indian or Asian, of course, is more than 25 is a risk factor. Ethnicity means, if you're Asians, if you're South American, if you're Islander, etc., then of course you're at higher risk than if you compare to the Caucasians, like the Germans, Americans, and Europeans.
So already have slides.
Saurabh, if Saurabh wants, he can share that. Otherwise, I'm just going in my flow. So okay. So the BMI was not. Yeah. Saurabh, if you can. Yeah. So the BMI was not very high. Of course, the BMI of 23 kg per meter square. I think this is probably pre-pregnancy or even the first trimester. That is okay for for Indians. Of course, we consider BMI 23 is okay. 23 to 27 is overweight. More than 27, grade 1 obesity or class 1 obesity. So she was diagnosed with gestational diabetes at 18 weeks of time. I'm not sure why the investigation was done at 18 weeks. What was the real indication? Was it just because that she was considered to be, she has a precious pregnancy and she has IUI, and that's why it was done? That may be one reason. But of course, it was done at quite a bit early time. Normally, we do a 24-week in our clinical practice, unless and until the patient has pre-existing gestational diabetes mellitus history or strong suspicion. So now she's coming at 24 week of gestation, and I can see that her sugar profile is not great. The diagnostic criteria again is so confusing. There are so many criteria, whether we follow DIPSI because patient come non-fasting and we can do it now, whether we should follow IAD SPG criteria, whether in Australia people follow the International Association of Diabetes and Pregnancy Society group criteria. Of course, in US, they have different criteria, but whatever we follow, I think we should stick to the same. That is the bottom line, because of course, with DIPSI, there are papers to suggest that we're probably missing few, maybe especially patient with fasting hyperglycemia, we're missing them. And 24 to 30% patient might be missed. But again, if you're following your patients up with ultrasound and all, of course, you can make some other suggestion about whether you want to repeat that or not. That is a different question, different talk. Again, if someone being diagnosed with diabetes in first trimester, maybe a good idea to do HbA1c. If it is not done, we should do that, because if someone has HbA1c of more than 6.5, and even in first trimester, you will say that, okay, in spite of having hemodilution, your HbA1c is 6.5%. So probably you have pre-existing diabetes rather than gestational diabetes. Patients, if you give them the choice, of course, everyone jumps on the tablets. I want to be on tablets. And if you read the books, they will say, yes, you can give glibenclamide, you can give metformin. But in real world, whatever I realized when I was practicing there and working there, that we were not able to achieve good glycemic control by metformin. I didn't use glibenclamide because it does cause hypoglycemia, it does cross placenta. I was not very comfortable, and it's not easily available. So there are a few reasons. So I'm not going to talk about glibenclamide because I'm not using that, and I have not seen many people using this drug in any case. It's more in books rather than in practical world. So in the question which we have, this lady who is 24-week pregnant, primary, the question is whether we go for oral anti-diabetic medication, which is metformin, or should we go for insulin? If insulin, then should we go for basal insulin, or should we go for prandial insulin, which is pre-meal? And how are we going to monitor the patient? Whether we are going to monitor it every day or alternate day, and we are going to check it pre-breakfast, pre-lunch, pre-dinner, or post-breakfast, post-lunch, post-dinner and fasting, or 6 times a day, pre-post, sorry, 8 times a day. So there are all those questions which comes in our mind. So if I start with number one, that this patient who is, suppose this patient is sent to me in my clinic and I have to see this patient, then the first thing I will say to my patient that, look, you are just 24-week pregnant. Your hormone resistance, which is there, which is basically the pathophysiological thing, that, okay, your human placental lactogen, the HPL hormone, HPL is going to increase insulin resistance. So HPL is going to work against you. Your cortisol, your growth hormone, your placental growth hormone, your insulin per se, insulin resistance, these are all the factors which are going to play a very significant role, and your insulin requirement is going to be double in pregnancy. Now your this is like a stress test for pancreas. So normally walking at like half an hour, you walk 2 kilometers. Now I'm asking you to walk half an hour, 4 kilometers. So of course that is a stress on your body, on your muscles, and that will be a test for your muscles. The same way the pancreas is going to be tested in pregnancy, because in pregnancy everything, all the requirement goes up, whether it's the cardiac output you talk about, whether all these all these other parameters, whether you talk about the thyroid hormone requirement. So I will tell my patient that, okay, everything, all the requirement for insulin is going to go up, your insulin resistance is going to go up. With that type of sugar of which is very high in my view, I don't think that 128 and 184 of blood sugar I will be able to control with tablets. So I'm not going to even offer you the tablet. End of the story. That will probably be blunt, but I think that's what I have to tell my patient. I don't want to tell my patient, give my patient false hope. I see few people, they are probably good and very considerate, but pregnancy is not like 18 months or 2 years affair. It's just 9 months thing. And that 9 months for the baby is like 90 years of the extrauterine life. So whatever changes is happening in 9 months, that many changes, that much changes doesn't happen after they have come out of the womb. So whatever we are doing, if we are wasting, suppose 1 week, it is probably equivalent to wasting a year in someone else's life. So I don't want to waste my time in advising about insulin and going, okay, go for tablet, let's see, give you metformin, and come back in 1 week time, 2 weeks time, and go and do doctor shopping and go 3 places and take opinion from and go for the public opinion poll from the doctors, something like that. So I will go, okay, go for insulin. That is number one. Number two, the information in this case, Dr. Bagchi, I would like to see what is the pattern. So if your patient was diagnosed at 18 week, I'm expecting that your patient is getting the home blood glucose monitoring. If the patient is a little bit educated, they can all do that very well. It's not so difficult now, neither very expensive nowadays. You get strips in 10 rupees if you look for, look properly. So I ask my patient, okay, do blood sugar monitoring 4 times a day. Okay, even if it is 18 week, the target doesn't change. The target remains the same. So the fasting, we say, okay, keep less than 95. The 2-hour postprandial, keep less than 120. I also see there are sometimes people do it 1 hour, 140 target, 1 hour. I think we should try to keep it very simple. Evidence is more for 95 and 120, so probably stick to that. If your patient is someone who goes to bed at dinner time and doesn't have that much time, so patient had dinner at 12 o'clock. There are patients, especially from old Lucknow, and they go to bed at like 1 a.m. so they don't check it 2 hours. So in that case, maybe I can give them some leverage. But ideally, fasting 2 hour post meal. If there are 2 or more blood sugars are abnormal at particular point of time. So suppose in 1 week time, there are 2 values at lunch time, they are above target in 7 days. I normally start something for that sugar. Unless and until I have a good explanation that हमने शरबत पी लिया और हमने शिकंजी पी लिया or कुछ भी something like that. If there is no good explanation, patient is following the diet, blood sugar is going up at that particular time, I start injection. Again, with injections, I think people get confused. Every day there are so many insulin types. My practical advice is that choose one, stick to one. It doesn't matter too much whether you're using Fiasp, whether you're using NovoRapid, whether you're using Humalog, whether you're using Epidra, anything. I'm not a great fan of Actrapid anymore because the problem with Actrapid is that you have to give half an hour early. Now patient doesn't wait for half an hour to have meal. So that's why I have stopped using that in pregnancy. I do use it other time. And for basal insulin, Lantus, if the patient is already on glargine insulin, then there is no problem. There are enough data. You can continue the patient on glargine. That is all right, no problems. But if it is de novo and you start something, then I do not start patient on glargine. If you ask me my choice, then I will say I will go for Insulatard, which is like an NPH insulin. NPH is not commonly used except in pregnancy, so it's very difficult to find in market. So you have to get it through your pharmacy somewhere, or one of the endocrinologists practice. Normally, if someone has pharmacy attached or nearby pharmacy, they keep this injection. NPH, again, I do not write patients, okay, go and take the insulin by vial, because in pregnancy, the insulin requirement is generally not very high. And I don't think that, saving some, few hundred rupees is really worthwhile, because if they get complications, of course, they will have to pay a bit more than what they save. So I will say, okay, go for pen. Pen is easy, the compliance is better. So Insulatard pen is a huge and throw pen available. Get your patient to get Insulatard. The other insulin which I use in pregnancy as a basal insulin is, I go for Levemir. The Levemir is insulin Detemir. It has a good data in type 1 diabetes and also in pregnancy. So these two insulins normally I use. I generally go for use and throw pen. I don't bother about cartridge, this, that, because the patient is already going through 10 other things. And I don't want to give them one more reason to worry about. So I try to make it very simple. I normally ask my educators to educate the patient, even if they are not going to take insulin, so that they can get this insulin phobia sorted. Because unless and until they get this 4mm needle, which is almost painless, once you just tell them that this is the insulin, you have to take insulin, the patient just feel like, okay, it's going to be a painful procedure, this, that. So they don't take it because they have fear, phobia. So these preventable things, I'll say, okay, we'll go for insulin, go and get one shot of like air shot type of thing, not insulin shot, and see how you feel. The pH of insulin is 7, which is basically our pH in our system. So it doesn't have a problem like a stinging sensation. Having said that, the only insulin which has acidic pH is glargine or Lantus. So Lantus does stings a bit because the pH of Lantus is 4. So if you inject, you feel a little bit of like ant bite, that's it. But in any case, it is probably a little bit more painful than the other injection. So in any case, I'm not using glargine in new patients. So I save myself from that side. So the question here is that what to do next. So that the answer very simple is, if the patient has only one value, of course, I can't say what to do. I need two values to be abnormal. So I will advise my patient that, okay, start checking the blood sugar, come back in a week's time, because it's not yet the phase at 24 week. I'm not too much worried about that this baby is going to be macrosomic. So I think I have time at this time. So I will say, okay, go home, monitor your sugar. In fact, if you can maintain a food diary, it will be great, because there is a very much discrepancy between what patients say and what they do, just like us, what we say and what we do. There's a discrepancy between all that. So I think I will say, okay, make a food diary if you can, write your sugars, come to me. Then I will advise insulin. Now, Dr. Manjusha, of course, we work together in Sahara. So we used to have fairly close association, and we used to have discussion about insulin dosing and all, how to start, what to do, etc. So she asked me that what we were doing, whether I can, tell everyone else here on the platform. So actually, it's an art. So it's not like that I can advise about how to treat GDM with insulin in 15 minutes presentation. But basically what you do, number one, I have seen people starting insulin with 2 units or 3 units or something like that, like short acting. You don't have to do that. Don't worry that much, because it's an insulin resistant state. So your patient is not going to get severe hypoglycemia with the insulin of 3-4 units. It's very, very, very unlikely. So don't worry too much. Just with the name of insulin, that patient is going to be in hypoglycemic coma. They will all have the awareness, the symptoms. If they do get hypoglycemia, the patient is going to have symptoms. So it should be still fine. And I don't think that you increase the risk of miscarriage when your blood sugar is less than 70. I don't think that really happens. So I will say, okay, start with at least maybe 0.2 unit per kilogram body weight if you think. So if your patient is suppose 100 kilos, then 20 units, 70 kilos, then 14 units or something like that. So that should be the insulin dose in 24 hours to start with. Increase it quickly. Don't waste that much time, like 2 हफ्ते बाद आना फिर देखते हैं, वो नहीं करना है. Give them the plan day one. भाई देखो, ये इंसुलिन तुम्हारा है, हम तुमको दे रहे हैं. Suppose that you started your patient on Levemir 6 unit, हमने दिया, and then it's okay. तुम्हारा लंच टाइम बढ़ा, डिनर टाइम बढ़ा है, ब्रेकफास्ट के बाद ठीक है. So I will give you 4 units and 4 units. So 4 4 8 और 8 है 6 14. तो आपको पेशेंट is 70 किलो, you given 14 unit of insulin. Now 14 unit insulin बहुत ज्यादा नहीं है, पेशेंट का कंट्रोल शायद नहीं होएगा. So what do you say कि भाई, you go home, monitor your sugar. If 2 of your blood sugar values are abnormal, suppose 2 of the fasting values are more than target, which is 95, then you don't come to me, just increase your insulin by 2 units. So 6 to 8, 8 to 10, 10 to 12, 12 to 15, 14, whatever, go up to 40 units, no problems. We don't have to be scared. Dr. Manjusha has seen the patients. I was giving the patients like 50 units 4 times a day, like 200 units, 250 units insulin per day, that type of. And then they used to come for the, betanol injections, and we were giving all those other stuff. So it's not it's a number. So we don't have to worry about that. Okay, मेरे patient को 40 यूनिट इंसुलिन चल रहा है, बहुत अब नहीं दे सकते हैं, ऐसा नहीं है. Insulin resistant state है. Patient is not accepting insulin, so give more, no problem. So normally I say, okay, if I'm not giving you insulin at breakfast time, but if your post breakfast value, in spite of having good diet, is more than 120 2 hours after breakfast, then please start insulin by yourself. Take 4 units. Patient will not remember all that. You have to write it down, or one of the assistants should write it down. It's a good idea to have protocol, some form of protocol in practice that saves time. If you make it, it takes a bit time. What I really missed about my training, that when we were doing residency at that time, at least in medicine department, I can say in our department, it was caseload full case load and pretty busy, but we didn't have protocols written. So JR3 used to tell us the protocol to JR2 and JR2 used to tell protocol to JR1. Now there is always a chance that you miss something that is not very safe, and that takes a lot of time. So it's a good idea to have a protocol. You can have a half A4 size paper, and you can just write that dose of basal insulin is blank, that many units, dose of prandial insulin blank, this many units, increase the insulin dose by 2 units every third day. If your post breakfast, this insulin, if your post breakfast value is more than 120, increase this, increase your basal insulin dose by 2 units. If your fasting is more than 95, it's very easy. So, so I will say, okay, to my patient, go home, do self titration, come to me in 2 weeks time. If the patient comes to me and sugars are still not great, of course, I don't increase by 2 units. I increase by more than that. I may increase by 8 units, 10 units, whatever I feel appropriate at that time. What I felt in my, during my stay in Lucknow, that a lot of patients used to spend a lot of time with that very slow type of titration, or taking very low doses for 3 weeks or something like that, that was a bit worry. I think Dr. Manjusha want to say something.
Yeah, I just want to know in short, what message do we want to give to people regarding this case? Like if we have a 20-weeker or 24-weeker who is not controlled, and how much by weight should be the starting? Like if he's 70, we start at 14 units. Half of 1/5 of the weight is what you are trying to convey.
So very right. I think you got the message that 0.2 unit per kilogram body weight.
Fair enough. And how do we divide it between the long acting and the short acting? Again, 50-50.
Okay.
So suppose we have a 70.
50 of both basal and 50 of bolus. 50 of bolus divided in 3. So at least 15. So basically 15% into 3, that is 45% as a bolus insulin and around 55 as a basal insulin, something around that. If your patient is requiring 4 injections, but if your patient profile is like that कि हम नाश्ता करते ही नहीं हैं, हम तो सिर्फ दोपहर में खाना खाते हैं, रात में खाना खाते हैं, in that situation of course आप breakfast time में नहीं दे रहे हो इंसुलिन, क्योंकि breakfast के बाद शुगर ही नहीं बढ़ा उसका, तो you are just writing lunch time.
मोटी बात ये कि जो बंदा नॉर्मल पूरे तीनों टाइम खाना खाता है, तो उसको हमको 45% हम लोगों को एज लॉन्ग एक्टिंग देना है, और बचे हुए का 1/3 तीनों टाइम पे देना है, और हमको उसका शुगर चार्टिंग करके देख लेना है कि कहाँ पे ऊपर नीचे है, तो उसको ऐसे टाइट्रेट करना है. Have I got it right?
दो बिल्कुल सही. 2 यूनिट बढ़ाना है हर तीसरे दिन.
ठीक है.
We can have this discussion because we have 2 more cases in line. So I think we should switch over to the second case, which is presented by Dr. Kumudni Chauhan. May I have her slide, please?
Thank you.
Thank you, sir. Thank you, sir. We'll continue with the discussion, the next case.
डॉक्टर चौबे, आपको जाना नहीं है, आपको भी 2 केस और समझाने हैं.
हाँ, sir. We'll continue. I said we'll continue with the discussion in the next.
नहीं, I'm not going anywhere. I'm just here.
Yeah.
I prepared
So, Dr. Kumudni, are you here?
Yeah. I'm here.
So yeah, Dr. Kumudni is the director of Ganga Lakshmi IVF in Lucknow, and she's a very, very dynamic IVF specialist. So over to you, Dr. Kumudni, with your case.
Thank you, Dr. Varda, and good afternoon, sir, and my respected seniors. And I welcome you, Santosh sir, in virtual platform of Lucknow. So, sir, this is case number 2. And sir, actually, this is a real case scenario, but my patient is right now 28 weeks, but here we just taken this case of 32 weeks pregnancy. And so Mrs. X, her age is 32 years, IVF conception, just because of ovulatory dysfunction and repeated failed IUIs. And again, in this case, GDM was diagnosed early. We did it in view of obesity and history of PCOS. I advised diet control and walk, etc. But there was no control, so we referred her to endocrinologist. And right now, she is taking insulin Lispro 13, 16, 18 units, and insulin Detimir at night 25 units. And as she is 32 weeks, so we decided for betamethasone cover and hospitalization. And post first dose, her sugar values are fasting blood sugar 95 milligram per dl, PP breakfast 180, pre-lunch 101, PP lunch 206, pre-dinner 97, PP dinner 256, and at 2 a.m. so 265. So, sir, my question is, was hospitalization mandatory, or we can give this betamethasone cover on OPD basis and ask her to monitor as she was already monitoring? And if hospitalization, then how long, for 48 hours or more? How frequent sugar charting to be done? Just right now we are doing just like that or something else? And sir, what will be the insulin dosing on day 1 and day 2, and maybe obviously after second dose too? Thank you, sir. So yes, sir.
Thank you, Dr. Kumini. It's a very interesting case. If I can answer quickly to your questions to 1, 2, and 3, that will be number 1, hospitalization necessary? The answer is yes. How long? At least 2 days, maybe more. How frequent the monitoring should be done in this situation? Pre-post and pre-post. So if your patient is having 3 meals a day, then at least 6 times. Sometimes if you're treating your patient aggressively, then you also need to check blood sugar at 2 a.m. So sometimes 7 times. So of course, patient can't check the blood sugar 7 times at home and adjust the insulin. So they need to be in the hospital. That's better. And what with the insulin dosing on day 1 and 2 and post-steroid? Normally I increase it by 50 to 100%. That is the insulin dosing. And yes, for how long? 2 to 5 days. That is the quick answer. I have answered all this question because now I'm going to talk a bit more. So at least you don't leave, lose the message. So that was the answer. But now the question is that, okay, so she's 32. She's of course a precious pregnancy. You said IVF, so of course she already had other issues. She's, from pregnancy perspective, she's a little bit older, 32. She might have family history because looking at her insulin requirement, she does have a significant requirement. She might be insulin resistant as well. I don't know her weight, but she might be pre-pregnancy weight, might not be normal. I expect she's not on any other medications which is causing insulin resistance, but yes, she might be on one. Insulin wise, I think she's on good regimen. She on injection Detamir, which is Levemir, which I use. If you compare between these two insulins, that is like a pearls of medicine. Whether you compare the use of, there are a lot of patients who come to you or me, and they are on Levemir and their fasting is not under good control. You go for injection Insulatard or NPH, because practically Detamir is not as strong, as efficacious insulin as Insulatard. So if you are in that trouble, fasting is still high, go for Insulatard. Insulatard works for 12 hours. Detamir works for around 20 hours. But for fasting, they're both very good insulins. Number two, you said that your patient is on Detamir and also on Lispro. So Lispro, I guess the patient is taking it pre-meal 13, 16, and 18. I hope your patients, the portion of carbohydrate is not more than 50% of the total calorie intake. In normal people, when suppose a patient comes to me with type 2, not pregnant, then I say, okay, 60% of your diet can be carbohydrate. But if the same patient is pregnant, you don't go for 60%, you cut back on the carbohydrate. This is something which is quite a bit miss, and dietitians are not aware of the differences. So they go for 60% in everyone, whether they are pregnant or not pregnant. So you need to tell your dietitian, if you have one or whosoever she goes to, that in my diabetes in pregnancy diet chart, I want carbohydrate to be 40 to 50% of total, not 60%. So that you have to do. Number 3, you said that whether this patient require hospitalization. Again, I noticed that in my practice that many gynecologists, they gave you the patients betnesol as a outpatient basis, and sometimes the patients who were not known to have diabetes and they became florid hyperglycemic after having injections. That also happens. So I think it is a good clinical practice for anyone that if you are giving betnesol, at least by glucometer, you should check the blood sugar next day before you give the next dose, because you don't know what really is happening with that patient. There are different steroid receptors in the body. That is why one patient you give a steroid and patient become totally lunatic or depressed or maniac. Other patient doesn't have any effect. One patient give a steroid become osteoporotic. Other patient doesn't have that bad osteoporosis. So there are steroid receptors are different. So the response of the steroid is different in everyone. One need to understand that. In your patient again, she already have high insulin requirement. She is going to get hyperglycemia. Now you should ask yourself that how much time it's going to take before she will feel the effect of injection. The answer is around 4 to 6 hours. The next question you should ask yourself, how much time is going to have the peak effect of the insulin of betnesol? So the answer is again 12 to 24 hours. The next question you should ask yourself, how long this patient is going to have impact of this medication on the blood sugar? The answer is up to 5 days. Other question you should ask yourself, how long this patient is going to have the effect of hyperglycemia, which may be worrying. The answer is 48 hours. These are the few questions you should come to your mind, and the answer you should know. So suppose you're giving yourself patient, your patient today in outpatient clinic, your patient saw you 12 o'clock. At 2 p.m. you gave her betnesol or dexamethasone. In fact, in today's talk, what I learned, which is new, is that they said that if you are giving steroid in pregnancy, the betnesol works better for the boys and dexa works better for the girls. This is new information for me. I don't know whether in Gynae society it has been spread or not, but that was the today's lecture which I heard. So it was interesting. Anyway, so if the patient is getting dexamethasone or betnesol, dexa works longer than betnesol, but ultimately the total duration is 5 days. The dysglycemic effect is for 5 days. But after the last dose, suppose you gave the first dose today and second dose tomorrow, the patient will require around 48 hours after the next dose, patient will have the impact, significant impact. So what my normal practice was that if you ask theoretical question, all of them will require insulin infusion if you go in the books. That doesn't happen practically because your nurses are not trained. You don't have supportive, that much trained staff who can monitor blood sugar every hour, overnight. They have 10 other things to do. That's not possible. So what I think which worked very well in my practice, or it still works here, is that I say maybe if you increase the insulin by around 50 to 100%. So if your patient is taking 13 unit, at least the next dose will be 50% increase. So 13 plus maybe 7 more, 20. If the patient, and you check postprandial blood sugar, which is 2 hours after dinner, and nursing staff, if she calls me and tells me that 2 hours after is 180 or something like that, or 200 or something, then the morning dose I normally increase by 100%. So 13 will become 26. Easy. Now, people again, this phobia of hypoglycemia, and people are worried. Your patient is admitted in the hospital. Why? What is the phobia about hypoglycemia? The patient will tell you the symptoms. You ask, you let patient know these are the symptoms. It is very unlikely to happen. But patient in the hospital, if she's going to land in a problem, it's more than likely that she will land in a problem because of hyperglycemia, not hypoglycemia. So I think if you give them even 100% extra dose, if you give the second dose of prednisol next day, the day after, she will still require 100 to 150% extra dose. So either you start insulin infusion. We all have protocols. It's widely available intranet, internet, and you can all download that and write your own. But normally it's either, okay, if there are 3 different type of patients: insulin sensitive, moderately sensitive, insulin resistant, this, that, very sensitive, and moderately sensitive, resistant, and then you give insulin infusion 1 unit, 2 unit, 3 unit per hour. So normally we say, okay, 40 यूनिट इंसुलिन सिस्टर को बोलो, 40 यूनिट इंसुलिन लीजिए सिस्टर एक्ट्रापिड को, 40 में नॉर्मल सलाइन में मिलाओ, इंसुलिन पंप तैयार करो और उसको इंसुलिन स्टार्ट करो. Now again, what dose? It depends on the insulin requirement. Like your patient is requiring, suppose 40, 50, 60 unit a day. She is insulin resistant. She will definitely require more than that what she is requiring. So if suppose her total requirement is 60 unit, you assume that she will require 100 units per day. So if she is requiring 100 units, then probably you need more insulin in the daytime when she's eating and all, less in the night time. So probably 2/3 in the daytime, 1/3 in the night time. So you give 30 in the night time. So 30 divided by suppose 8 hours, so that will be around 3-4 units at that time. But in the daytime, post meal, pre-meal, she may require 6, 7, 8 units per hour, something like that. So it all happens. It's very dynamic thing. But what the practical thing is for you, that I will say that, okay, increase insulin by 50 to 100%, do pre and post. If you're not getting in target, next dose should be, of course, a bit more, maybe 25-50% more than what you gave, and keep your patient at least for 2 days, preferably for 3 days in the hospital. Let your patient know when you go home, monitor a bit more frequently, watch for hypoglycemia. If that happens, treat yourself. Now there is another very good strategy which not many people use. There is something called insulin sensitivity factor. So suppose my insulin requirement is 50 units, and I want to know that if I give myself 1 unit of insulin, how much my blood sugar will drop in 2 hours if I don't eat anything. So that is called insulin sensitivity factor, or ISF, or correction factor as well. So the simple formula is that you take a number 1500, 1500. 1500, you divide that by total daily dose. So that will be around 50. That will be around, I think, 30 milligram per deciliter. So 1 unit of insulin will drop the blood sugar by 30 milligram per deciliter in normal person who is not pregnant. Now, if your patient is pregnant, that number will be further probably down. So it may be 20, 25, something like that. So if your patient's blood sugar is high, suppose that you ask the nursing staff to check the blood sugar, and she calls you at 11 p.m. and say that, Madam, iska blood sugar to 280 hai. What you do, you don't need to sit overnight ki main kal subah dekhungi isko. You need to do something. 2 options again. Number 1, whether you ask the nursing staff ki bhaiya isko start insulin infusion. Option 2, you give her the correction factor or based insulin dosage short acting. कितना देना है, तो उसका आपको चेक करना है कि आपका होना चाहिए था 120 और आपका है 280. So 280 minus 120 कर दो आप, you got 160. 160 बच गया आपके पास. 160 को आप 30 से डिवाइड करो, आपके पास करीब करीब 6 नंबर आएगा. तो आप सिस्टर को बोलो कि सिस्टर जी, इनको 6 यूनिट इंसुलिन लगा दो, 2 घंटे बाद फिर चेक कर लेना, देख लेना क्या है. अगर बढ़ा रहेगा तो आप सिस्टर को या जो भी जूनियर स्टाफ उसको समझा दो कि बेटा ये इसको 1500 डिवाइडेड बाय टोटल डेली डोज से इसका इंसुलिन सेंसिटिविटी आ रहा है, इसको तो इतना यूनिट 2-3 घंटे में दे सकते हो, शॉर्ट एक्टिंग इंसुलिन, कोई दिक्कत नहीं है। फियास वगैरह 3 घंटे काम करता है, वैसे भी दे सकते हो। बहुत आपको डर लगता है तो आप 4 घंटे भी दे सकते हो, बट यू कैन गिव प्रैक्टिकली। अगर इंसुलिन पेन चलाने में प्रॉब्लम है तो यू कैन डू दैट। तो ये तो आपका क्वेश्चन का जवाब था कि हाउ टू एडजस्ट इंसुलिन डोजेस। आई थिंक आई हैव डन विद ऑल दिस 3 आंसर्स। अब फिर भी इफ यू हैव अ क्वेश्चन, आई एम वेरी हैप्पी टू आंसर।
थैंक यू सर। एंड सर, जो ये दे रहे हैं हम लोग, जो आपने कैलकुलेशन बताया है, तो ये हमारा जो शॉर्ट
जी
एक्टिंग है वो दे रहे हैं ना सर?
जी बिल्कुल शॉर्ट एक्टिंग दे रहे हैं। जो 2 से 4 घंटे काम करता है वैसे इंसुलिन देनी है। तो फियास दे सकते हो, नोरेपिड दे सकते हो, हिमोलॉग दे सकते हो, पिड्रा दे सकते हो। यस।
एंड सर, हाउ टू गिव इंसुलाटार्ड?
इंसुलाटार्ड में इंसुलाटार्ड आपको
If
1 से
we
2
want to
बार
give in
देना
this
है।
case, sir, as you are saying,
आपके केस में
fasting is not controlled.
नहीं, तो इसमें तो मैं एक बताया कि एक पैटर्न, इफ यू सी ए पैटर्न इन दिस सिचुएशन, यू नो दैट यू हैव गिवन स्टेरॉइड, सो दैट्स व्हाई फास्टिंग इज नॉट कंट्रोल। तो इसमें चेंज नहीं करोगे आप। बट देयर आर लॉट ऑफ पेशेंट्स, आप उसमें लेवेमिर दे रहे हो 50 यूनिट, पेशेंट का शुगर फिर भी बढ़ा हुआ है, तो यू हैव टू चेंज द इंसुलिन एंड दैट इज द इंसुलिन। बट इन दिस सिचुएशन उसको आप 50 to 100% बढ़ा दो, और 3 दिन तक तो आराम से बढ़ा सकते हो, कोई टेंशन नहीं है। ये
Thank you, sir. Thank you.
Thank you, sir. Thank you very much for this extensive and elaborate discussion. With this, we move on to the third case by Dr. Apala. Can I have a slide? Dr. Apala, are you there?
Yes, ma'am.
Okay. So over to you. Can start.
Can I have the case? Okay, very good evening to respected teachers and seniors. At the outset, I thank Dr. Manjusha ma'am for giving me this opportunity to share this platform with the stalwarts in the field. And it's an honor to have this crosstalk with Dr. Chaube sir. Now, my case is this patient, Mrs. X, 30-year-old primigravida, and she's 39 weeks pregnant. Gestational diabetes controlled on oral metformin 500 milligram BD. She was diagnosed at GDM at 25 weeks with DIPSI showing 175 milligram per deciliter. Of course, we first tried her on medical nutrition therapy and she wasn't controlled, so we started her on metformin 500 milligram BD. Her fasting blood sugar recent shows a reading of 89 and a 2-hour postprandial shows a reading of 118, which means that on metformin, she's well controlled. And now she's at our place and we are planning her for induction of labor the next day. So we want to know that what are the special precautions that we need to take before induction? What should be the frequency of blood sugar monitoring in this patient? How should we give her insulin for optimal glucose control? What are the choice of IV fluids which are warranted? And the management of glucose values in the immediate postpartum period after a cesarean section or if she undergoes a vaginal delivery.
Thank you, Dr. Apala. I'm not the stalwart number 1. Madam लोग वहाँ हैं वैसे. So if I start with, आप पहले वाला slide, डॉक्टर अपाला की slide लगा दीजिए जरा, सौरभ प्लीज, वहीं पे आ जाओ. नहीं, डॉक्टर अपाला आपकी स्लाइड एक बार और हम देखना चाहेंगे. I will just give you one liner for all the questions and then I will go for a bit of more elaborate discussion.
Please give the
So,
previous
trying to find
slide.
your slide.
Just with them only.
नहीं मिल रहा है तो आप अपना शेयर कर दो. You can
Okay,
share.
okay, sir. I'll share my screen. They say you cannot start screen sharing while the
अच्छा
other
कोई बात नहीं,
participants.
don't worry.
अरे इससे पहले जो दिखाया केस के बारे में वही था ना. क्वेश्चन क्या है तुम्हारे?
शेयर करने
Sir,
पड़ेंगे
the
वो
first
उनको
question is
शायद.
what are the special precautions to be taken before we start
हाँ, बस
induction?
क्वेश्चन बता.
नहीं ठीक बात है. So I think ये कुछ शेयर तो कर रहे हैं.
आ गया.
तो मैं एक लाइन पहले बता दूं, उसके बाद फिर बताएंगे. So पहली बात यह है कि स्पेशल प्रिकॉशन, मतलब प्रिकॉशन in a way that induction, when you're doing the induction, I guess induction में एक एक्टिव फेज ऑफ लेबर जो होता है उसमें आई एम श्योर यू नो मोर देन मी अबाउट ऑल दैट, कि उसमें तो उसका इंसुलिन रिक्वायरमेंट कम हो जाता है और पेशेंट का कैलोरी रिक्वायरमेंट बढ़ जाता है और उसका जो एक्सपेंडिचर है वो बढ़ जाता है. तो unless until your patient has type 1 diabetes, उसमें तो insulin की जरूरत, अगर even if the patient is on insulin, they mostly do not require insulin. About metformin, ideally one should stop metformin if it is a planned induction. Ideally it should be stopped 24 to 48 hours before delivery. एक तो ये वाली बात है. Then the next issue is कि how often should you monitor the blood sugar, जैसे आपने पूछा. तो how often means your patient is fasting, so maybe 2 hourly blood sugar monitoring is all right. Monitoring enough is not enough. You need to know what are we going to do, what is the alarming number. So if your patient blood sugar is more than 70 and less than 110, then you just sit back and relax. I don't think you need to worry too much about that number now. But if the patient blood sugar is going more than 110, then you need to think about doing something, because we all know that even if it is 4 to 6 hours of hyperglycemia before delivery, that increases significantly the chance of neonatal hypoglycemia as well as hypocalcemia, both, of course, with other issues as well. So monitor too early, think about target. 70 to 110 is fine. More than 110, we need to do something in the form of giving some insulin. Whether you give infusion or whether you give in the DNS, we'll discuss about that later on. Third, when and how to use insulin. I already spoken about when. The how is infusion. You give maybe insulin infusion pump, or if not possible, then you can give insulin mixed with DNS or dextrose normal saline. Next is the choice of intravenous fluid. Normally is normal saline. Normal saline is fine, but if a patient is developing hypoglycemia, blood sugar less than 70, then you can give 5% dextrose, or sometimes we give DNS as well when we give insulin mixed with DNS. But preferable, if you ask, then separate insulin and 5% dextrose is better. Normal saline, if blood sugar remains between 70 to 110, just give normal saline. Don't worry about giving 5D or DNS or anything like that. That's fine, because patients do have glycogen stored in the muscles and the liver, which can take care of the requirement at that time. Next one is what is the management of glucose values in immediate postpartum period, after cesarean section or after having vaginal delivery. So your patient will probably, insulin sensitivity improves markedly. So there is a risk of hypoglycemia, both in type 1, type 2, and as well as in GDM patients. If the patient is on insulin for type 1 diabetes, you reduce the insulin by 100% in a way, like you cut that in half. So if someone taking 20, that patient will take 10 only of all this insulin. If the patient is on type 2, then maybe if the insulin requirement is not very high, suppose the patient is only on maybe 20, 30 unit of insulin, stop insulin altogether, that is perfectly fine. The target is not the pre-pregnancy target. Now the target is different. So if suppose that the patient blood sugar is less than 130 pre-prandial, less than 180 postprandial, that is perfectly fine. I don't think that patient will have increased chances of infection, etc. with that level. That is not a problem. Just like the target for type 2 diabetes, just follow that target. The frequency of monitoring is, the patient is nil by mouth, then you do it 4 to 6 hours. If the patient is eating something, then again you can do in postpartum state, you can do it pre and sometime in the night, like pre-breakfast, pre-lunch, pre-dinner, and midnight or something like that. So that's the summary. Now, if you go a little bit of detail, So if I ask the first thing, the role of metformin in pregnancy, that is a very debatable topic. The recent study, which is a MIGHTY study, which showed that if the patient is, metabolically fine, then you can give metformin, no problems. But if the patient has proteinuria or hypertension, then they found that metformin is associated with the decreased birth weight. So maybe you should stop metformin in those patients and use insulin in that situation. Number 2, the blood sugar monitoring in labor. I think we have already said that 2 hourly is fine. Target we already discussed. More than 110, give something. Of course, insulin. Insulin infusion, if you want to use, normally you start with ask your nursing staff to prepare 40 units of insulin in 40 ml normal saline. Use a syringe driver. Start with 1 to 1.5 unit per hour. Not a lot, because especially in active phase of labor, not eating, her insulin requirement will be low, not high. So low insulin requirement, but it will be there. Increase as per need. IV fluid, normal saline is a good one. Blood sugar less than 70, go for 5%. More than, if the blood sugar is more than 110, normal saline is fine. The patient you can't use insulin pump and all, insulin syringe driver, then in that situation, you can try DNS with 6 to 8 units of normal saline at 100 ml per hour. If your patient's sugar is going to go up more than 110, then you give more insulin. So ask the nursing staff to put extra insulin in the DNS to make it more, insulin concentrated in a way. The patient is going down, then maybe you need to change the IV fluid with a lesser amount of insulin. But there is no set guideline how to use DNS and insulin drip, which is most commonly used method, but there is no guideline for that, unfortunately. Postpartum, I think we've already discussed. So I think I have finished with the discussion for this case, but I will be very happy to answer questions if someone has or you have one.
So just one more question I wanted to ask. Like when I was reading on this, I was reading one article where they said that they prime the IV drip set with the insulin if you are using the insulin as an infusion. So what is your take on that? So are you doing that, priming
that is very right, actually. Insulin does stick to the tube, so it is the part of the protocol that if you are using insulin, you don't have to prime in a way. Basically, you nursing staff normally they know it, that they can just go for free flow of around 4 ml of fluid out of the 40 ml, and that primes the drip. So that you can do, and then you should do for anyone, whether it's pregnancy or non-pregnancy.
Thank you, sir.
Thank you.
Thank
Anything
you, sir.
else? The problem. Anything else? If any clarification from audience, I will be happy to answer. If not, then that is fine.
I request Dr. S.P. Jaiswal, ma'am, to kindly give her opinions in all the cases which we have discussed.
Thank you, Manjusha, for inviting me for the expert opinion. I think Dr. Santosh, he has covered so nicely in a very simple way to how to manage this patient. And I congratulate Dr. Shipra, Dr. Kumudni, and Dr. Apala for presenting their case wonderfully. They have kept a variety of cases on this platform. As we know that as a obstetrician, we manage this GTM in our day-to-day life. And in the maximum cases, Dr. Santosh, we are the person we always, because the patient comes to us first, and when we fail or when we want opinion from the endocrinologist, then we take opinion from them. But ultimately, we have to manage, because the 9 months the patient is with us even after delivery of again the patient is with us. So with opinion, with the expert consultation of endocrinologist, we manage the patient. So in first case, as the patient is conceived by the IUI, she has diagnosed at GDM at 18 weeks. Although according to Indian guideline, once the patient come to us, although she is a case of IUI or infertility managed case, so I feel she is already having blood sugar before conception or even the first trimester also. Otherwise, if there is a new case, we have to do the blood sugar with the 75 gram glucose in every patient once she becomes conceived, whether in the first trimester, second trimester. So we want to pick the case as early as possible. So if she has come in the second trimester and diagnosed as that, the role of HbA1c is very important. Even all patients, although the organogenesis has occurred, but still we can counsel the patient if it is high. If it is normal, then we will relax because the HbA1c is normal. Okay, so this is the one thing. Second, if the blood with the Indian guideline of DIPSI, the 75 gram glucose, we take 130 to 140. 120 is the normal, 140 above is abnormal, and 130 to 140 we keep under observation and we try to control by diet. So in this patient, the first blood sugar was 180. It was high, more than 140. And our aim is to control the blood sugar as early as possible. Although she has already passed organogenesis, so in that, definitely first we try by the nutritional method, medical MNT. Then we go for the oral metformin. In the second trimester onwards, the metformin is the best choice. Even the patient can take it orally, and with this borderline, there is no close monitoring is required, and the patient does not go for the hypoglycemia in this situation. But in the third case, when the blood sugar is quite high, definitely the patient needs admission and insulin. We prefer insulin in the mixed rod form, like that the NPH, because in this we titrate the blood sugar in a much better way. So we prefer that. So we have to keep the patient in the hospital and we manage. Once the blood sugar is controlled, then we teach the patient how to use this. We teach the patient how to use the insulin, and with this she can monitor at home and can come with the reading of the blood sugar from fasting, postprandial, that is the must if it is under control, or she can do the random first in the fasting blood sugar, even sometime after lunch, 2 hours after lunch, or sometime after dinner. So there is no need of 6 or 7 times of blood sugar once she has been controlled. So she can come with this reading to us, to the hospital, to show whether she is controlled. She can continue the pregnancy. Third question occur when it should be given about the betnosol or corticosteroid. So for that, again, we have to, as Dr. Santosh has already covered very well, we have to admit the patient and give the betnosol or corticosteroid, and at the same time we have to increase the dose of insulin accordingly. So in this situation, my message is that we have to keep the patient in the hospital and then give the insulin, the betnosol, along the increasing dose of whatever the required. Because once she is in the hospital, we can monitor very well. There is no problem, but we can't ask the patient because we are working in the government setup. And if anything happens, then it will be very difficult. And our patients are not so educated also. So we keep in them with us. And it takes 48 to 72 hours to come to the normal or previous dose. So this is about it. Third thing is about the induction. On the third case is the induction of labor, who is having the metformin. As Dr. Santosh says, once we are planning this induction, metformin should be stopped at least 12 to 24 hours before. And even the guideline, Indian guide, ACOG also says that once the blood sugar is controlled, we can go and leave the patient for the spontaneous onset of labor. But she has already reached 39 weeks. And in that, if you are planning for induction or cesarean, whatever it is, in that situation, we have to stop the metformin. And as she's having very lower dose, so I don't think she required insulin. And as we We know in the fast, when the patient is fasting, we are planning for the cesarean section. First, we take the fasting blood sugar and put the insulin in the bottle, depending upon how much the blood sugar is having. Fasting blood sugar is there. So this is the management. And even labor, she does not require insulin if she is controlled by the metformin, because she is not on higher dose. Even if she is having very high dose of insulin, still we have to calculate and accordingly we manage that, because in the regular dose in this we cannot give, and patient is not able to take proper diet also during labor. So we have to give the insulin if it is required according to need. And after delivery, definitely the insulin dose will decrease. As we know, this pregnancy is a diabetogenic condition, so after delivery it reduces. But the management of the baby is very important, as this baby they go into hypoglycemia very quickly, so the baby needs breastfeeding very quickly or very early, and baby needs to be kept in NNU at least for 24 to 48 hours till the blood sugar is control or stabilize. This is the overall summary about the case.
Thank you, ma'am. You have beautifully summed up all the information given by sir and summarized in a nutshell. Thank you so much, ma'am. With this, we switch over to the next part of the session, the most coveted part of the session, which is the debate. So here.
Thank you. Manjuji, do you want to say something?
No, but I want to thank everyone and go. And नहीं कुछ कहना नहीं है, बस thank you डॉक्टर साहब.
Dr. Santosh,
what?
I'm right?
Or
anything wrong in this?
नहीं,
want to correct
नहीं. And mode of delivery depends actually if there is any obstetric indication for cesarean, only then we plan for cesarean, and it should be planned as cesarean then, no emergency this thing. And big size baby, which is a cause for cesarean in diabetics, तो cesarean का management तो फिर फर्क ही हो जाता है. तो thank you very much. मजा आया सुनने में.
दो बातें मैं ऐड कर सकता हूँ अगर तो. दो चीजें बस मैं कहना चाहता हूँ. एक तो प्रैक्टिकल बातें अगेन. एक तो ये जो रिलायंस ऑन एंडोक्रिनोलॉजिस्ट अबाउट मैनेजमेंट ऑफ डायबिटीज या जेस्टेशनल डायबिटीज वगैरह है, it is not safe for our country. Our country is big, huge country. There are 10-15 endocrinologists in Lucknow, maybe. पूरे उत्तर प्रदेश में शायद 20-25-30 होंगे. Now, every day in Lucknow, there might be, 100 deliveries or 200 deliveries. I don't know how many. And out of them, maybe 25% have gestational diabetes. तो अगर आप 25% केसेस रोज एंडोक्रिनोलॉजिस्ट तो या 25 क्या ज्यादा ही होते होंगे डिलीवरी, आई थिंक 1000 होते होंगे, तो इतने केसेस तो देख नहीं सकता कोई एंडोक्रिनोलॉजिस्ट. तो
नहीं तो डॉक्टर संतोष, हम लोग को वैसे हम लोग अपने आप ही इतने एक्सपर्ट हो जाते हैं ना.
नहीं मैम
कि हम लोग खुद ही मैनेज कर लेते हैं.
नहीं आप वही पॉइंट मेरा वही था मैम. हम लोगों को एक सेट गाइडलाइन अपने डिपार्टमेंट में, आपके डिपार्टमेंट में, हर जगह पे जो भी इंटरनेशनल गाइडलाइंस है, एग्जाम 1 2 3 4 जो कि एक जूनियर स्टूडेंट फर्स्ट ईयर भी
इंटरनेशनल गाइडलाइन पढ़ाने के लिए तो ठीक है. आरपीजी शुड नो अबाउट दैट आल्सो, एसीओजी और जो आरसीओजी गाइडलाइन है, फॉक्सी. लेकिन जो हमारी फॉक्सी की गाइडलाइन है, दैट इज क्वाइट गुड फॉर इंडियन पॉपुलेशन.
वही सेम फॉक्सी की गाइडलाइन
फॉलो करें.
फॉक्सी की गाइडलाइन उसको मतलब दे हैव टू हैव अ गुड कम्युनिकेशन अंडरस्टैंडिंग कि ऐसे जाओ 1 2 3 4 सो दैट चांसेस कम हो जाएंगे. दूसरा ये मैम मिक्सटार्ड मतलब एनपीएच तो बहुत अच्छा इंसुलिन है और
बहुत अच्छा है डॉक्टर साहब. हम लोग अगर भेजते हैं
हम लोग थोड़ा अवॉइड करते हैं. मिक्सटार्ड शायद नहीं देना मैम, बिकॉज मिक्सटार्ड में थोड़ा सा ये होता है कि उसमें शॉर्ट एक्टिंग इंसुलिन भी होता है, तो उसको एडजस्ट करना दिक्कत हो जाता है. तो उसका फास्टिंग बड़ा हमने मिक्सटार्ड में वो एक बढ़ाया तो वो पोस्ट डिनर वाला गड़बड़ होने लगता है.
बॉर्डर लाइन के लिए तो हम लोग प्लेन यूज करते हैं डॉक्टर साहब. अगर हमें थोड़ा बहुत चाहिए 1-2 इंसुलिन तो हम प्लेन यूज करते हैं. लेकिन अगर हमें मान लीजिए कि नहीं हमें चाहिए तो फिर भी कीप ऑन एनपीएच, बिकॉज लॉन्ग एक्टिंग में इट्स वेरी डिफिकल्ट टू कंट्रोल. सो हम लोग को लिए बीन इन द एज ए ऑब्स्टेट्रिशियन हम लोग को मिक्स्ड वाला ये 30-70 वाला वी फील मोर कंफर्टेबल. अदरवाइज वी कीप ऑन प्लेन इंसुलिन.
और हम लोग अगर मेटफॉर्मिन पे पहले से पेशेंट है तो उसको मेटफॉर्मिन कंटिन्यू करने देते हैं।
Continue.
वो तो मैम
के पास।
that is a standard advice. No
हाँ।
no problems with that. But if the patient has proteinuria and hypertension, दो कंडीशन ऐसी है, प्रोटीन्यूरिया और हाइपरटेंशन वाले पेशेंट में IUGR के चांसेस ज्यादा होते हैं, तो उन दो पेशेंट्स को थोड़ा सा देखना पड़ेगा, बाकी जो जितने हैं दे शुड बी कंटिन्यू।
और डाइट कंट्रोल तो बहुत ही इम्पोर्टेंट है, वो सबके संग एडेड होगा ही होगा। तो थैंक यू,
ठीक है,
बाय बाय।
यही दो बताना था। थैंक यू
Thank you, Dr. Santosh.
And I will
You
leave
have
now.
covered
I think,
very well.
I will.
Please,
Thank you so
Dr.
much.
Santosh, please stay with us because now we will be coming to a very interesting session, which is the debate. The topic of our first debate is it is a patient of NIDDM controlled on metformin, and she conceives with IVF. Should we switch over to insulin? And for this session, our judges are Dr. Reenita Das was supposed to join us, but for some reason she is not able to join us. And Dr. Sunita Chandra is also busy. She's stuck up with some emergency. We have Dr. Tanushri, ma'am. Are you there? Dr. Tanushri? Dr. Geeta Khanna, ma'am, we would be very happy if you are here. You can be the judge for this session.
Hello, Varda?
Yeah, ma'am. Yeah,
very much.
Okay, ma'am. Okay, great, ma'am. So Dr. Tanushri, ma'am, is will be the judge for this session, and the speakers here are Dr. Fareha Khatun. She'll speak for the topic. Dr. Fareha.
Yes, ma'am.
So she's a consultant in Apollo Medics Hospital, and she'll speak for the topic.
Okay, ma'am, can I share the screen?
Yeah. You over to you, Dr. Fareha.
So thank you so much, Varda ma'am, for your kind introduction. And I'm really thankful to Manjusha ma'am for making me a part of this academic feast. And the crosstalk was really very informative. Thank you so much, Santosh sir, Jaswar ma'am, and Manju ma'am, for very lucidly explaining how to deal with insulin in the management of pregnant women. So we have gathered so much of information, but the debate is still on. And the topic for the debate is a patient of non-insulin diabetes mellitus controlled on metformin conceives with IVF. Would you switch to insulin? And I'm really happy to answer this question that yes, I will switch to insulin. So insulin remains the preferred therapy of diabetes in pregnant patients. The American Diabetes Association recommends insulin therapy and states that other agents during pregnancy should be limited. So the government of India also supports insulin as a drug of choice in the management of diabetes and pregnancy. After the metformin in GDM study, many centers have started using insulin as first line in GDM. However, more data are needed in Indians. So the recent consensus statement by the American Diabetes Association has further recommended that insulin is the preferred agent for the management of type 2 diabetes mellitus in pregnancy. So no doubt we had started using metformin, but the facts revealed in this consensus statement are quite alarming. Metformin no doubt lowers the risk of neonatal hypoglycemia and causes less maternal weight gain. But we all know that metformin really crosses placenta, and it has been shown that the umbilical cord blood levels of metformin are as high or higher than the simultaneous blood levels in the maternal blood. Excuse me, ma'am, I'm not able to clearly see the full screen. I think I'll minimize. Okay, no. Yeah, so again, in this clinical practice guideline, it was shown that the 2 RCTs of metformin used in pregnancy for PCOS follow-up of 4-year-old offspring demonstrated higher BMI. The further follow-up at 5 to 10 years showed higher BMI, weight to height ratios, weight circumference, and a borderline increase in fat mass. A systematic review and meta-analysis conducted in 2019 on neonatal, infant, and childhood growth following metformin versus insulin treatment for gestational diabetes has shown quite alarming results. The following intrauterine exposure to metformin for the treatment of maternal GDM, the neonates are significantly smaller than neonates whose mothers were treated with insulin during pregnancy. Despite lower average birth weight, metformin-exposed children appear to experience accelerated postnatal growth, resulting in heavier infants and a higher BMI by mid-childhood compared to children whose mothers were treated with insulin. Such patterns of low birth weight and postnatal catch-up growth have been reported to be associated with adverse long-term cardiometabolic outcomes. The Society for Maternal and Fetal Medicine also says that due to the potential for growth restriction or acidosis in the setting of placental insufficiency, metformin should not be used in women with hypertension or preeclampsia or the women who are at risk of FGR. So now again, we have switched to insulin. The safety profile of insulin has been proven since decade. So as the pathogenesis of type 2 diabetes mellitus, Dr. Santosh has clearly explained it is because of the insulin resistance and defective insulin secretion. So the demand for insulin rises during pregnancy. So we have to supplement the insulin during pregnancy. So insulin is not just a medicine. Insulin receptors are found in almost all the organ systems of the human body. And apart from maintaining glucose homeostasis, it has many other functions also, both central actions and both peripheral actions, as seen in this graph. The insulin is responsible for the cognitive function. It causes increase in the cognitive function. It decreases depression. It causes decrease in the food intake. And it causes hepatic glucose, decreases the hepatic glucose production, increases lipogenesis. So basically, insulin is not just a medicine. It is a physiological hormone. So suppose if there is a deficiency of insulin in the body, it can only be replaced with the help of insulin only. So the multiple studies have proven the safety of insulin in pregnancy. So to summarize, insulin is the preferred therapy for the treatment of non-insulin diabetes mellitus in pregnancy. So this, I thank everyone.
Thank you, Dr. Fareha. Now, Dr. Achal will speak against the motion. Dr. Achal?
Yes, ma'am. Ma'am, I'm just sharing my slides.
Dr. Achal is the Director and Chief Fertility Consultant at Colors IVF and Fertility Center, Lucknow. And thank you for joining us. Over to you, Dr. Achal.
A very good evening. A very good evening to all my respected seniors, teachers, dear colleagues, and friends. I thank Dr. Manjusha ma'am for giving me this opportunity to share this prestigious IFS platform with distinguished seniors and experts in the field. So as we all know that metformin is a drug which is widely recommended in clinical practice for the treatment of women with PCOS for its heterogeneous effects on metabolism. Over the last decades, the tide has turned quite dramatically in favor of metformin for the treatment of diabetes, both pre-existing and newly diagnosed in pregnancy, since the first study that used metformin in pregnancy in 1979. So despite the various methodological issues with this, the overwhelming conclusion from these studies is that metformin is safe in pregnancy. There have been no reports of an increase in congenital abnormalities or deleterious effects on fetal growth or short-term neonatal health. In fact, several studies have described a number of beneficial effects of metformin. So here I am speaking against the motion. In 1995, the bicarbonate metformin was approved by FDA for use in patients with NIDDM. It's an orally active, synthetically derived, water-soluble biguanide, and it has anti-hyperglycemic effect without causing hypoglycemia. The indications are type 2 diabetes mellitus and anovulatory women with PCOS. So now So now the metformin use is expanding beyond the diabetes care. Now metformin, as we know, reduces hyperglycemia by suppressing gastrointestinal absorption of glucose uptake. It inhibits hepatic glucose output and hepatic gluconeogenesis, increases insulin sensitivity, and enhances peripheral tissue insulin-stimulated glucose uptake. GDM, as we know, is associated with several adverse outcomes over short and long term for both mother and offspring. The primary goal of therapy for gestational diabetes mellitus is to achieve euglycemia and thus decrease the adverse perinatal outcomes. Theoretically, insulin sensitizers should have been the ideal agent in the treatment of GDM, but fetal concerns have outweighed practical utility till the recent past. Oral hypoglycemic agents are cost-effective, patient-friendly, potentially compliance-enhancing, and also more physiological, given that the insulin resistance is likely to be the main pathogenetic mechanism of GDM. Metformin has been in use since decades for the patients of type 2 diabetes mellitus and also for many years now in insulin-resistant PCOS patients. But its use in pregnancy was limited until studies have now shown that it is safe. Now, the metformin in gestational diabetes trial was a landmark study, being one of the largest randomized controlled trials in women with GDM. And they concluded that metformin alone was not associated with increased perinatal complications. And this trial has been the basis of many subsequent studies to assess the safety and efficacy of metformin use in GDM. And even after a follow-up study, which followed up the children at 7 to 9 years of age, these data are reassuring for clinicians using metformin in women with GDM. Until recently, insulin was the only medication recommended for use in patients in pregnancy for women with pre-gestational diabetes. Women treated with oral hypoglycemic agents were advised to switch to insulin when they became pregnant. But studies have found metformin to be as effective as insulin for the treatment of diabetes during pregnancy without increasing the risk of neonatal or maternal morbidity. Guidelines now promote the continuation of metformin from pre-pregnancy into the gestational period. And RCTs have demonstrated the efficacy of metformin for treatment of GDM compared with insulin, and its use is supported in GDM treatment guidelines. The WHO, the Australian Association, and the Canadian associations all have recommended the use of metformin, and they have recommended it in settings where insulin administration has logistic or compliance issues. So if they can be used there, then they can be used in general for all the patients. The NICE guidelines have also suggested metformin as the first line drug in GDM. And there is good acceptability and favorable outcomes in the Indian population as well. A normal pregnancy is associated with a 50% reduction in insulin sensitivity in the third trimester, and this is compensated by 200% increase in the production of insulin in order to maintain a euglycemic state. Metformin treatment combats both these effects by increasing insulin sensitivity and reducing the basal hepatic glucose output. So one of the most consistent observations from the metformin studies to date is the reduction in maternal weight gain, during which is likely to be associated with long-term health benefits for women. And maternal hypoglycemia is also much less prevalent in women treated with metformin alone. So the postnatal effects of metformin in GDM was a study with 1996 children born to women with GDM were treated with metformin, and 1932 were treated with insulin. And it showed no difference in child growth and neurodevelopment between both the groups.
Sorry to interrupt you, Dr. Achal. Please try to wind it up early because you've already crossed the time limit.
Yeah, sure. So metformin was used for PCOS for PCOS pregnancy, and 18.7% incidence of miscarriage is seen in non-treated PCOS patients, and it is reduced to 10% women who received metformin up to 32 weeks of pregnancy. So metformin has been supported. The use of metformin has been supported in PCOS patients as well. Even in gestational obesity, it has reduced the incidence of weight gain. The MOP trial is evidence of that, and a Cochrane review also supported that. So metformin does not stimulate the secretion of insulin, and therefore it does not directly cause maternal hypoglycemia, a side effect that remains a concern with both glyburide and insulin. So a reduction in future life risk of obesity and metabolic syndrome in the offspring is there. Also, it reduces the incidence of preterm delivery and late miscarriages, and it also reduces inflammation in pregnancy. And it improves endometrial dysfunction in PCOS disorder, which helps in reduction of miscarriages. Also, there was a worldwide web-based survey where 50,800 cycles were reported, where metformin was continued till delivery in 12% of the patients. And they found encouraging results. 70% of the IVF cycles reported increased pregnancy rates due to the use of metformin. And a majority of cycles also noted that metformin may reduce the rate of miscarriage, with 36% reporting certainty with this finding. So does first trimester exposure to metformin increase the risk of birth defects? There is currently no evidence regarding that. And so to conclude, the disadvantages of insulin are multiple daily injections, risk of hypoglycemia, maternal weight gain. Insulin requires modification based on patient's BMI, glucose level, and lifestyle. Detailed guidance for dose change of insulin is necessary to ensure safe self-administration of insulin. Substantial costs of health education on safe use of insulin, as well as the cost of drug. Benefits of metformin are lack of severe adverse effects and low cost, have positioned metformin as the best risk-benefit ratio. RCT using metformin have shown slight reduction in maternal weight gain, and studies show lower serum levels of the inflammatory markers, and therefore there is reduction in preeclampsia. And it is also associated with the reduction of severe hypoglycemic episodes and PIH. Also, it reduces the risk of preterm delivery and NICU admissions. And the studies have shown reduced weight gain in women with GDM treated with metformin. So metformin can be safely used during the first trimester and in pregnancy. There is currently no evidence that metformin is associated with an increased risk of major birth defects in women affected by PCOS and treated during the first trimester. Thank you.
Thank you, Dr. Achal. We have Dr. Tanushree as the judge for this session. I request Dr. Tanushree ma'am to kindly give her opinion on the two speakers. And
yeah, first of all, good evening, Dr. Santosh. It is really nice to see you on this forum after a long time. And good evening, all my dear friends. So now we have been using metformin for a pretty long time. Now the thing is that basically our motive should be to have the fasting sugar of not more than 120. So if a patient is very well controlled on metformin, now Dr. Achal has given all the evidences that metformin is a very safe drug. It is cost effective with no history of major congenital anomalies in the fetuses. Rather, it has the very beneficial effects and especially who go into pregnancy. So if the blood sugar is very well controlled on metformin, I have, as Dr. Santosh has also given the target of 95 and 120 pp. So if the patient is controlled on medical nutrition therapy and metformin, I don't think that we need to switch over to insulin in these type of patients until and unless there is some contraindication, if the patient are vomiting or GI side effects, or if there is any other history for which we have to switch over to insulin in these patients. However, as Dr. Santosh has already said, that controlling blood sugar is easier with insulin in the patients who are having very high blood sugar levels. And here I like to take the opinion of other delegates or panelists also, because normally in GDM patients, most of the GDM patients, I have seen that we can control it with the medical nutrition therapy and with the use of metformin. But in type 2 diabetic patients who go into pregnancy, normally in most of the patient, we need to put the patient on insulin. So I don't know, but I like to take the opinions of others also. So these are the things, and we have to take care of certain things with metformin, like the vitamin B12 levels. We have to see that. And one more thing, good glycemic control in pregnancy is very, very important, in the sense that insulin is not going to cross the placenta. The fetus is going to sense only the glycemic levels, blood sugar levels. So there are sufficient studies to show that where the maternal blood sugars are high and not well controlled, and the level of life, such fetuses are more prone to develop diabetes mellitus. So if we want to change the epigenetics of the coming future generation, I think a strict glycemic control is very, very important in such type of pregnant ladies. And for a very strict glycemic control, I think insulin can be a better therapy rather than metformin. But we do not have any protocol or guidelines to shift over from metformin to insulin if there are good glycemic control. Now, one more thing, as Dr. Santosh has very beautifully explained everything, I think for these patients, what we are following is the BBT, that is the basal bolus therapy. And he has very beautifully explained that how to start with the basal insulins, then add the bolus wherever needed, whether it can be +1, +2, +3. So, and everything. So I'll not go into the details. And I'd like to take his opinion also, that whether Dr. Santosh agrees with what I have just said. Dr. Santosh,
I perfectly agree with you, ma'am. I think whatever you said, that is perfectly right. That, you know, if someone is good, has good control on metformin, of course, if there's going to be induction and then you stop at 24 to 48 hours before induction, that is fine. But otherwise, they're not really a great need. And the good thing with metformin is, of course, that the compliance with metformin is better than compliance with insulin. It is easy to take. Patients find it difficult to take insulin. Of course, there is all those resistance about insulin use. So I think in that situation, metformin does have a very good role to play. So we can't negate that. But at the same time, you know, they are like complementary. Insulin and metformin, they're all complementary. So we just need to use them.
And the cost effectiveness also, Dr. Santosh, especially.
Yes. This cost, you know, we are not comparing, like, it's not a head-to-head trial between insulin and metformin about cost effectiveness. But
and as Dr. Santosh has already said, that if there is an element of hypertension or proteinuria, then
in those two situations, with the current trial, Mighty trial, which is published 2022, they say that it causes decreased fetal weight and with significant p-value. So I think in those situations, I will probably avoid that. And chronic hypertension, and proteinurias.
Proteinurias.
Yeah.
Thank you, sir. Thank you, ma'am. Thank you, Dr. Ma'am. Thank you, our speakers, Dr. Archel and Dr. Fareha. And I'm really very happy to say that Dr. Sunita ma'am has just joined us.
Vaida, before we proceed, we have.
Oh, sorry.
Dr. Fareha and Dr. Archel.
Yeah.
He's being happy to award multiple certificates. This is for Dr. Fareha and this is Dr. Archel. I hope you can see them. Can you visualize?
Yes, thank you so much, ma'am. And thank you.
Please can applaud them virtually.
Okay.
Thank you, ma'am.
Thank you so much, ma'am. Thank you, everyone.
Thank you. I'm stopping share.
Okay.
Please proceed.
So, yeah. As I was saying, I'm really very happy to say that Dr. Sunita ma'am has just joined us. Dr. Sunita ma'am, are you there?
Yes, I'm there.
Okay. So for this session, which is a debate on a case of GDM, which is well controlled on multi-dose insulin and need not to be delivered before 39 weeks, We have with us Dr. Sunita Chandra ma'am, Senior Infertility Specialist, Morpheus IVF, Lucknow, and Dr. Amrit Gupta as the judge. Speaking for the motion, we have Dr. Indulata ma'am. She's the Professor, Department of Maternal and Reproductive Health, SGPGIMS, Lucknow. So we begin with the first talk. Dr. Indulata ma'am.
Yes. Good evening to all of you, all my seniors and my colleague. And first, Dr. Vardha, you have to stop sharing. Actually, somebody is sharing the screen.
Who's sharing? I'm sharing? I'm not sharing.
Yeah. No,
Field person must be sharing now.
Yeah, the host might be sharing. I'm not sharing. I'll just request them.
Okay.
No, we are now seeing Dr. Indulata's screen.
Mm-hmm.
Dr. Indulata, we are seeing your screen right now.
Yes. So, first, I would like to thank the Dr. Santosh, Dr. Manjusha ma'am, and whole IFS team to invite me for this debate. And today I am debating in favor of this topic, that is a case of GDM well controlled on.
Manjusha ma'am, please unmute yourself.
Okay, just a minute. I'm unmuting. 1 minute. मैं कहीं और खो गई थी. Give me a minute.
We have something to say.
मैं unmute हूँ.
Okay.
So today I am debating for case of GDM well controlled on multi-dose insulin and need not to be delivered before 39 weeks. So to introduce with, gestational diabetes is defined as any degree of hyperglycemia that is recognized for the first time during pregnancy. It also includes cases of undiagnosed type 2 diabetes mellitus identified early in the pregnancy and true GDM which develops later. It is also associated with short and long-term complication for the mother and the fetus. So when we call the well-controlled diabetes, basically, so when the fasting blood sugar levels are less than 95, 1 hour postprandial blood sugar less than 140, 2 hour postprandial blood sugar less than 120 milligram per deciliter, and any time the preprandial blood sugar should be less than 99 milligram per deciliter. So timing of delivery in gestational diabetes is very complex and it is guided by the maternal glycemic control in addition to maternal and fetal factors, and it has not been definitively established till now. So starting with my studies, of course, this is not my study. So in this scenario, so first study published in Canada in 2020, and they had taken 4 groups of diabetes patients. First one was with type 1 diabetes, second group was type 2 diabetes, third group gestational diabetes, and fourth group was of control without diabetes. And these all patients delivered a singleton infant at or more than 36 completed weeks of gestation. So in results, iatrogenic delivery was associated with increased risk of neonatal morbidity and mortality at 36 and 37 weeks of gestation among women with gestational diabetes. And there was low risk of neonatal morbidity and mortality at 38, 39, and 40 weeks of gestation. That is slightly advanced gestation. Second study was conducted in 2019. And this was evaluation of fetal lung maturity by quantitative analysis in women with gestational diabetes mellitus, in which they had taken total 96 women between the 36 to 38 weeks of gestation. And they had divided the 3 groups, one with gestational diabetes with diet control, gestational diabetes with diet plus insulin, and one group with normoglycemic women. And they evaluated the fetal lung maturity by a non-invasive method of quantitative ultrasound analysis of fetal lung texture. So in results, they found a significant percentage of pregnant women with gestational diabetes treated with insulin had fetal lung immaturity in the late preterm to early term. So they had more maturity at late term and term gestation. Third study is published in 2017. They enrolled 100 women with insulin treated gestational diabetes, and they made two groups, that is 38 weeks group, that is group 1, and 40 weeks group, that is group 2. And induction of labor was done in these two groups. And in result, they found that the success rate of deliveries within 48 hours after induction of labor for 38 weeks group was less than the 40 weeks group. And in newborn, in 38 weeks group had increased rate of neonatal hypoglycemia than 40 weeks of group. And the fourth study was conducted in 2016. And this was basically on induction of labor. They included women with gestational diabetes who had a single hospital birth at or more than 30 weeks of gestation. And they divided two groups. In one group, women who underwent induction of labor at 38 to 38 weeks, 6 weeks of gestation, and they were compared with their expectant group. And second group was those women who underwent induction of labor at 39 to 39 plus 6 weeks of gestation, and they were also compared with their expectant group. So in result, women in the 38 weeks group had lower rate of cesarean delivery, but they had higher rate of neonatal intensive care unit admission in comparison to their expectant group. And in women in 39 groups, likewise had low cesarean rate, but they had no difference in neonatal intensive care unit admission in comparison to their expectant group. So by this, we know this, that there is more neonatal NICU admission in the 38 group. In our guidelines in ACOG practice bulletin, they also stated that insulin is considered the preferred treatment for diabetes in pregnancy, and for women with gestational diabetes that is well controlled on medication, that is on insulin, delivery is recommended at 39 to 39 weeks, 6 days gestation. In women with vascular complication or poorly blood glucose control, the delivery is indicated at 38 to 38 weeks, 6 days of gestation, and even earlier if there is more complication. And scheduled cesarean delivery is advised when the fetal weight is more than 4.5 kg or more. In ACOG committee opinion, they also stated that gestational diabetes mellitus, well controlled on medication, the timing should be full term, that is 39 weeks, 6 days of gestation. And in NICE guideline, women with GDM should not be delivered no later than 40 weeks, 6 weeks of by induced labor or by cesarean section, and consider elective birth at less than 40 weeks who have maternal or fetal complications. And for pregnant women who have an ultrasound diagnosed macrosomic fetus, that is fetal weight more than 4.5 kg, explain the risks and benefits of vaginal birth and induction of labor and cesarean section accordingly. So to summarize, in patients who deliver at or more than 39 weeks of gestation, there is lower risk of neonatal morbidity and mortality. They have adequate fetal lung maturity, and it is attained towards the term, and low chances of cesarean delivery after induction of labor at or more than 39 weeks due to favorable cervical status and higher unit admission if induction of labor is done at less than 38 weeks of gestation. But the timing of delivery in a woman with gestational diabetes should be individualized because of various medical, obstetrical, and psychosocial factors which usually influence the timing of delivery. Thank you.
Thank you, Dr. Indulata ma'am.
It was a well-timed presentation, and it was a very nice deliberation.
So, ma'am, with our next speaker, Dr. Himani Negi ma'am. She is the senior consultant, Sahara Hospital, and she'll speak against the motion. Dr. Himani? Okay.
Dr. Himani, we can see your screen. You can start talking. Dr. Himani, can't hear you although. Please try to unmute yourself. Can the host please unmute Dr. Himani? हिमानी लेफ्ट बॉटम पे एक आइकन है ना, उसे क्लिक करो, अनम्यूट का ऑप्शन है.
Okay, I think.
Yeah, now I can hear you. Now we can hear you.
Yeah, can you hear me?
Yes, now we can.
Okay, okay. So sorry for this glitch. Okay, and yes. Good evening, everybody. First of all, thank you, Dr. Manusha and IFS for giving me this opportunity. And I'll be speaking for this against the motion, rather, that we should be delivering a GDM type A2 on insulin before 39 weeks. When Dr. Manusha gave me this topic, I said I'm just sitting back in this topic because all the guidelines, all the recommendations are with Dr. Indulata. And she was asking Bhuvneshwar Kumar and Ashwin to score a century against England in semi-finals. So anyway, khair ab to Pakistan jeet gaya hai. So let's get back to our topic. See, why do we need to discuss this thing? When all the guidelines say, yes, you can deliver a controlled GDM on insulin after 39 weeks. Because gestational diabetes itself is not just a disease. It is actually a conglomeration of medical, social, geographical, and psychological factors that a lady has and where the lady is from. We all have guidelines, but we need to see what postscripts they have, what we need to read in between the lines. Now, in RCOG guidelines, it's very straight away says that recommendations are not intended to dictate any exclusive course of management or treatment, and they must be evaluated with reference of individual patient needs. Coming back to ACOG practice bulletin,
Himani,
of timings. Sorry?
आपकी स्लाइड्स कर रही है.
स्लाइड क्या हो रहा है? ओके ओके, आप फुल स्क्रीन ऐसा करती हूँ मैं, मिनिमम पे ऐसे ही रखती हूँ, ठीक है ना? हाँ हाँ, हम क्या हैप्पी विद. ओके, when we talk of ACOG, it clearly says that consideration of timing should incorporate the trade-offs between risk and prematurity and ongoing risk of stillbirth. So we can consider delivery between 37 to 39 weeks. There have been very less randomized control trials about delivering the patients earlier than 39 weeks for obvious reasons. It's very challenging, but there is a Geneximals randomized control trial that spread between Italy, Slovenia, and Israel. There were two groups in which one was delivered at 38 weeks by induction and other was kept on expectant management. Interestingly, there were no maternal perinatal deaths. The induction did not increase the cesarean frequency. The only difference was that there was higher bilirubinemia in newborns with the women with induction of labor. Now, talking about the Emmy Metcalf study, Dr. Indulata said that there was a increased risk of neonatal morbidity if we delivered the patients early rather than the expectant management. Absolutely fine. But then there was a conclusion in it that the fetal outcome did not exactly depend upon the timing of delivery. It depended upon the indication for which the timing of delivery was planned. Then there was very good review by Roman Capistin, who reviewed about 50 articles about time and mode of delivery in diabetic pregnancy. He enumerated various obstetric and medical reasons and finally said that decision about term and mode of delivery in diabetic pregnancy should be made individually, and further RCTs are needed to provide a high quality data. Now, why do we need to talk about India specifically? Because India is different from Western countries. In India, doctor to patient ratio or a specialized neonatal intensive care unit ratio to patient ratio is not as great as Western countries. We have a very good article by Bharti Kalra in which the Indian perspective was put. We all know about medical and obstetric causes, but they added psychological factors and social factors. Social factors means how close the patient lives to a tertiary care center.
कोई बात नहीं, एक लाइन दो लाइन बोल देना, बस एक दो लाइन बोल देना.
Frequently she can visit or how the NICU care is at that center.
ठीक है, बस उसके बाद नमस्ते.
Now this
सही चल रहा है वैसे.
Manjusha ma'am, please unmute yourself.
Sorry.
Sorry to interrupt you, Dr. Himani ma'am, but there was a disturbance, so sorry.
There is something called guidelines, but there's something called experience. And by experience, we all agree that factors affecting influence of time of delivery in GDM type 2A, we need to consider the medical factors like in past history, the history of previous third trimester pregnancy loss, macrosmia, or previous cesareans. In this pregnancy, if we have a macrosmia with a patient at 37 weeks having 4 kgs baby, or loss of fetal movement, severe cholestasis with bile acids running 60 to 70, or a severe PIH which is not controlled. If the patient has frequent RBS fluctuations that are very difficult to control GDM, especially in a PGDM type of phenotype, or we have a severe polyhydramnios, we might need to consider terminating the delivery early. And of course, the psychological factors. If a patient is keen on a normal delivery and we have a 37-weeker with 4 or quarter to 4 kgs, we might explain the consequences to the patient and might need to deliver her. In social and geographical factors, as I had enumerated before, availability of a neonatal unit, availability of antenatal steroid coverage, or inability of patient to come for frequent follow-up, or the patient is living quite far from a tertiary care. These are such cases in which we need to interpret the situation and then act accordingly. So to conclude, the nature of gestational diabetes on insulin, it is very challenging. So there have not been enough randomized controlled trials. But if we gain from our experiences, we should understand that timing of delivery is a decision in which we should follow the guidelines, but we should also respect the biomedical, psychological, and social geographical factors affecting the patient. The bottom line should always be first, do no harm. Thank you so much.
Thank you, Dr. Himani. It was a very wonderful deliberation. I think you have put your point very justifiably right in all manners. And does Dr. Indulata have to say anything for the rebuttal? Hello, is Dr. Indulata here?
I think she's.
I am not. Am I heard?
Yeah, you are audible, ma'am.
Yes.
Yeah, because the network on my side is. So I thought that probably I might not be conveying what I am saying. So anything. Well, if Dr. Indu doesn't have anything to say, I have a little bit 2 lines to say that it was a very well said debate by both the candidates, and it is very justifiable to say that the delivery should be conducted after 39 weeks because the evidence says that. But as Dr. Himani, factors are to be considered while taking up the decision for the timing of delivery. And with our socioeconomic status, with our patient conditions, and the patients, most of the patients, they belong to the category who are very not that compliant, and there are so many other factors which timing of the decision. So the timing of the delivery is very much individualized, and that is what the message is to be conveyed and to be taken into account. Yes, we have to keep in mind that the delivery should not be very premature, otherwise there will be so many of the problems that we can encounter with this such type of pregnancy, but then we have to take it into account that the individualization of each and every patient should be there, and very well spoken, both of the speakers. And I don't think I'm in a position to judge. Both are very good, and if Dr. Manjusha has to say anything, she can.
We have
so it was very well
ma'am
conducted.
also. We can have our expert opinion. Dr. Sunita ma'am.
Yeah.
Dr. Sunita ma'am has emergency.
Okay. No issues, ma'am. So
I just want to say something, that we have to make actually balance between the decision regarding the delivery before 39 and after 39. So there are many factors which influence the timing of delivery basically. We can't stick on the guidelines basically. We have to individualize each patient according to the risk factors associated with this condition.
thank you, ma'am.
Thank you so much for bringing all the means going into the depths of the study and bringing all the studies forward to make a decision and to make a good conclusion.
I request Dr. Amrit ma'am to kindly award our speakers with the certificates.
Yeah, very well conducted debate. One is I welcome Dr. Indulata to have the this certificate, which is awarded for an outstanding performance for the debate of timing of delivery in GDM on multi-dose insulin. And also Dr. Himani Negi for again an outstanding performance for convincing us all about the importance of individualization in timing of delivery in GDM on multi-dose insulin. So congratulations to both of you, and the certificate is awarded definitely.
Thank you, Dr. Amrit ma'am. Thank you, our speakers, Dr. Himani ma'am, Dr. Indulata ma'am.
Thank you.
And with this, I request Dr. Manjusha ma'am.
No, Dr. Neelam.
No, I think you need to say something before she gives her vote of thanks.
It was amazing. It was amazing to have everything together. We learned so much.
Volume.
Is really
not audible.
About things which we are never.
Dr. Manjusha, you need to increase
ma'am,
the volume.
your voice is breaking. Manjusha ma'am, your voice is breaking.
Okay. So panel was very interesting. The cross-talk is a better way than the lectures, I thought. And debating, yes, we got to know the pros and the cons of both these things. I think it was overall a lovely experience being with all of you. And thank you all so very much. And may I request Neelam now to please propose a vote of thanks.
Thank you, ma'am.
Thank you, Dr. Manjusha, for giving me the opportunity to give the vote of thanks. I want to thank Dr. Sanjay sir, who has delivered the talk so well. All the Dr. SP Jaswar ma'am and Dr. Manju Shukla ma'am for giving their practical tips, especially in our scenario, because we have so many diabetes patients and they also come from very low socioeconomic background. So considering medications in GDM patient is also, the oral medication is also one good thing. And I also want to thank the debaters and the judges who judged them so well. The Shield Health Private Limited for giving us this platform for performing this webinar. And Dr. Manjusha for giving us this opportunity, and all the delegates who have joined from far places also for having the patience to listen to this webinar. So thank you all.
Thank you.
Thank you. Thank you, Dick.
Thank you, ma'am.